Nam. Okay, these are the picture of my clinic, of our system. Okay, we will start the subject today. My subject I want to show you today is the power of 3D simulation in diagnostic and orthodontic treatment. First, I know the famous sentence of Dr. Ronan wrote, "We spend too much time for treating and not enough time for diagnostic." So my presentation today is we will introduce about how to reduce the time and how to have the best diagnostic for our orthodontic treatment plan. First, we talk about the making a treatment plan. For making a treatment plan, it did not change so much from the beginning. The first part, we have to collect the records on the record of the patient. First, intra-extraoral picture. We can do it easily with a lot of software. We can do it also with WEBCEPH. Collect the X-ray, panoramic, cephalometric, collect study model. Then we're making a treatment plan. Okay. After the classic way for making a treatment plan, we have to do the soft tissue, smile, face analysis, then do cephalometric analysis. This one we do with WEBCEPH. And after study model analysis for measure the bone discrepancy or measure the mesodistal side of the tooth. Then for complicated case, we can do manual setup or we call manual simulation. I want to talk about the history of manual setup. In 1953, Dr. Kesling introduced about the 3D manual setup for complicated case for how to see the movement of the teeth. And we can see the movement, make the treatment plan for unusual situation. On the internet, we can look for the paper or a lot of article or introduce a 3D manual setup and how to do it. We can do it for a long time. So in 1956, on an orthodontics journal, Dr. Kesling introduced how he can do a 3D manual setup. Then this is the way we are doing now. It's really the same with Dr. Kesling after around 60 years. So the progress of the process of the way doing manual setup did not change so much. Of course, manual setup had a lot of advantage, but it had a disadvantage also. For manual setup, we have to take time in the lab, so it will be very expensive for us. If evaluate the movement is not easy. And if we have more than treatment plan, it's complicated for doing, or we have to do the 2 or 3 individual setup. And the most important thing is if we do the stripping on the model, we cannot redo it. We have to retake impression. And if we want to discuss with another dentist or consulting with the patient, we have to have the physical model, the beginning and the final setup. And now today we have 3D, so it will be easy for us. We have scanner, we have extraoral scanner like Reshape, Artero, and a lot of brand of 3D software, Invisalign, CleanCheck, or 3Shape, or NetShape, and 3D printer, 3D resin printer or FDM printer. And I had on in my practice. While we are using the 3D in orthodontics for record taking, for Invisalign, fully customized appliance or in-house aligner. But in Vietnam, when I just see 90% they are using the 3D for record taking and for Invisalign. They are doing in-house aligner, but not a lot. So we start the main subject today, 3D digital simulation in orthodontics, how it can be useful and how we can do it for orthodontic case. First, I want to tell about the advantage of 3D digital simulation compared with 3D manual setup. For segmentation, we can do it less time than the manual setup. It's easy. Moving the teeth or change anything has several options is faster and easier. We can evaluate the quantity and quality of the movement. And if we want to discuss in implant or prosthodontic case, we can send to another dentist easy and consulting with the patient. But for the disadvantage, we have to use the 3D object on a 2D display. It's not good. We can also print the model, but I think it's we don't need it, and the occlusal chain are harder to estimate. In my practice, we are using 3D digital simulation for first importance in my presentation is focus on diagnostic and lingual case or aligner case. Indication for diagnostic, first, normal case, unusual situation. For communication with the patient, we have several options. We have to discuss and choose the treatment plan with the patient. We explain about advantage and disadvantage of the treatment plan. Communication with other dentists, especially in pluridisciplinary case, and diagnostics for aligner lingual treatment. We will discuss about all of these things after. First, could I ask you one question? Why we have to do diagnostic simulation on normal case? Could you write on the chat room why we have to do diagnostic simulation on normal case? You can write anything you want or you are thinking, because I know you are thinking why we have to do the simulation on normal case. It's easy. We can decide treatment plan very easy. Okay, I'm waiting. Okay, so I will explain. Normal case in Vietnam or Asia are not really easy. We had 70% of adult patient and extraction case. We see missing the molar every day, a lot of rounding. So because we had the adult patient, almost the extraction case, so treatment time can be very long, take time around 2 to 3 years. So we had to do everything for reduce our treatment time. Everyday case, we can see the case, normal case with large tree, space on the upper and lower, missing the teeth on the upper and lower, mandibular lateral discrepancy, and frequent case like last case, last tree, anterior crossbite and posterior crossbite, a little crowding on upper and lower. So these cases are not orthodontic surgery case in Vietnam. And classic case, we saw it every day, a lot of rounding. So for our experience, okay, Dr. Pham Dung, for more prediction in tooth movement. Yes, I will talk about my experience. When I did the setup on the normal case, I changed the treatment plan around half of my case. Despite of I only need around 10 to 15 minutes for one setup, one option, but I can say several appointments, a lot of material and time of the patient on the chair. Even if I did not change the treatment plan, I will be more confident about my treatment plan and during the treatment. The patient will trust us more. And we had to ask instruction or non-instruction on this case. Why we had 70% of adult patients, so some cases are borderline. If we do non-instruction, it will be faster and easier. But after, if I change to instruction, because we cannot do with non-instruction, you have to take for longer time and the patient will not be happy. You say to them, we don't need to extract anything, but after you change to extract, of course, cannot happy. So if we do it, we decide to instruction treatment, we have to tell with the patient and we prepare for the long time of the treatment, take 2 or 3 years. Now we go to the clinical case. With clinical case and the simulation, I can explain easily and more clearly about why we had to do the setup on normal case and another situation. First case, we have anterior crossbite almost edge to edge on the center incisor, moderate crowding upper and lower. And when we see the X-ray, I want to keep the position of the upper incisor or just apply a little and show the anterior crossbite with retrocline the lower incisor for improve the patient profile. Okay, we see the simulation. First, I want to do a non-extraction treatment with this patient. Okay, for easy to see my simulation, I want to tell you about my about the reference. White part is for the beginning of the treatment and blue part is the final result. And I cut the saturated view of the 3D model. We can see the movement as we want, like the cephalometric. In this case, we can see we keep the position of the upper incisor and we retrocline only lower incisor. Okay, I procline a little on this case, and I did non-extraction treatment. What we have, we will see. Okay, we do non-extraction treatment. When we see on the simulation, we distalize number 37. This number 37 we distalize is around 6 to 7 millimeter to show the rounding and retract the lower incisor a little and show midline deviation. After we can see from a lot of the literature, it will be very risky for distalization 6 millimeter to 7 millimeter because we know the limitation of the mandible. So we cannot distalize a lot like this one. Sometimes we can do. but almost we can only do distalization of the lower molar around 3 to 4 millimeter. So I don't want to have the risky of my treatment. I change to extraction simulation. I change to extraction. So first I do extraction. But the first one, I just think I only need to do extraction on the lower. I extract only 3, 4. For this one, you can see we can do it only with the lower, because for the upper we can distalize just a little, like 2 or 3 millimeter. We can do with mini screw. It's easy. But the trouble is if we only extract the number 4 on the lower, the number 7 on the upper will not in occlusion. So we keep one premolar on the upper, but we lose one the molar on the upper, and we don't have the molar in the occlusion. So now I change to extraction on the upper also, and I extract 2, 5 on the upper and 3, 4 on the lower. Yeah, we can see this is for the anchorage. For sector 4, we have to use the mini screw, of course, but on sector 3 we might need the mini screw because we measure like the molar only 1 to 1.5 millimeter. Okay, after the first case, I think you know why we had to do the simulation and how it can be useful. I will discuss with you more case in normal case and explain more about the useful of the 3D simulation. Second case, we have moderate crowding on the upper and the lower. For the profile, the patient is okay, and with the profile and the position of the lower and upper incisor is almost good. So I just want to retract 1 to 2 millimeter of the incisor. So I did the extraction simulation for premolar extraction. Then what we have, we see for the upper it's okay. For the lower, okay, we will see this one. For the lower, we can see the number 36. We burn around 95% of the extraction space. We burn 95%. We only need around 0.5 millimeter. So only need 0.5 millimeter. Why we need extraction on this side? Okay, then I change to non-extraction on the lower left. For the upper, it's really the same. So for the lower left, we don't need to extraction, but we have to distalize around 0.5 millimeter. So I need the mini screw here. For this sector, we don't need the mini screw. Sorry if when I explain or you had a question, you can tap on the chat box, or you can tell me speak more slowly. Thank you. Then we can see the anchorage on the upper is not the same for both sides. For this one, we had normal anchorage, okay, but for this one, we may still lie around 1 to 1.1 to 2 millimeter, and we don't have number 7 because the patient only 12 years old. So we need the mini screw here. Then the third case, we had the space on the upper, impacted premolar on the lower, proclamation open by. And when I see the X-ray, I think this is an extraction case. I want to retrocline the upper a lot and the lower a little. The upper around 6 millimeter and the lower around 1 to 2 millimeter. Then, and I had to show the midline deviation. Then I do the extraction simulation. For me, when I see the case, I think, okay, this one is extraction case with 4 premolar extraction. For the lower, we had to use mini screw for absolute anchorage. And for the upper, you can see we retract around 6.5 millimeter on the upper, but we only need normal anchorage here. We may still line the number 5 around 4 millimeter. So I think okay, if we do if we only need 4 millimeter on the upper, we can do distalization. We don't need the extraction on the upper. I change to non-extraction on the upper. We see the simulation. For the upper and sagittal cut, it's the same thing. For the upper simulation, we had to distalize the upper 5.5 millimeter. The setup shows us we have to distalize the number 5.5 millimeter. And the most important thing is the occlusion. The occlusion both sides, the number 7, upper 7 is not in the occlusion. So like the first case, we keep 2 premolar. We don't want to extract 3 premolar. We have to use mini screw. Because distalization on the upper, we have to use mini screw. Very difficult for doing distalize 5 millimeter, and we lost 2 molar. Okay, the patient was not happy at all. Signal the molar is very important, so we chose the first option. If we sometimes in my clinic and for me also, I had some situation like this. I want to keep the premolar for the patient, and at the end of the treatment, I had the number 7 like this one. And after I had some discussion with the patient, an implant or extract the premolar and burn 100% anchorage. Oh, for me, luckily the patient is okay. He did not care about number 7. Okay, after normal case, we can see clearly and the benefit of the 3D simulation in normal case. So for unusual situation, of course, we need 3D simulation. When we consider about extraction the incisor, extraction the cannon, the patient only had 3 lower incisor, 3 upper incisor, lost 1 incisor by an accident or anything not normal. We had to do the 3D simulation for how the teeth fit, for how the teeth move, and my mechanic, how we can do it. The first case, the patient had crowding on the upper, open bite, and only 3 lower incisor. So for this patient, I had 2 options when I see the patient. And see it right, she had protrusion, jaw protrusion, upper and lower. So I want to retroline the upper and lower incisor around 2 to 3 millimeter. Cannot retroline a lot. First option I choose is 3 premolar simulation. 2 premolar on the upper and 1 premolar on the lower right. We see the simulation. For the upper, it's okay. No trouble here. For the sagittal side, okay also. We retract a little. But for the lower, we have to do asymmetric mechanic for this one. We had to train the cannon to the incisor, and we had to do stripping. Asymmetric mechanic is not easy, so we had to note it and very careful about it. And second option, I extract one lower incisor, and both cannon will be the incisor. For the upper and the sagittal side, the same thing. For the lower, we can see this is the cannon. This is the cannon, the beginning cannon. So after the treatment, we had to do stripping a lot on the incisor and the cannon for show the motor disturbance. So the amount of the stripping could be a potential issue. So I did not choose this option. And with this option, when we extract one incisor, we can have the black triangle between the lower incisor. So me and we choose first option. Then the second case, the case we extract one lower incisor, the big rounding on the lower, good occlusion, the minimal rounding on the upper. Okay, so the patient want to do a liner. With a liner, it's very easy. So I want to do the setup for seeing well, which movement we will have. Okay, perfect. We have the minimum movement on the upper and the lower. We can see it's easy with a liner, so we can do it fast, only less than 6 months. The treatment time only less than 6 months. Okay, after 3 months, we had the progress picture. The patient is happy. The third case, this is a very good case for showing how the simulation useful. When I saw patient, I really want to extract to the lower incisor. Why? Because we can do the treatment time very fast. We can do treatment very fast. But I cannot do it if I don't know clearly about what I have to do. The patient is okay with her profile. I want to keep or just retroply a little on the upper and the lower. She missing one, the molar. So first I do the option with extraction one, the premolar on the upper, and extract two lower incisor, opening space for an implant. This one, the picture show how we can open the space for an implant, and the occlusion is good. Okay, we can see the movement is not a lot, so the treatment time is fast, will be fast. Then I show her the second option also. The second option is I only extract one lower incisor on the right, and on the left I align the incisor and close the space, molar space. But we can see the molar space is quite big. So if I had to retract and apply the molar around 6 millimeters, for this one, the treatment time can be long, take around 2 to 3 years. And it can be a potential issue of the periodontal. So then I discussed with the patient. The patient is around 40 years old, and she the woman, so she just want to improve her aesthetic as soon as possible. She want to do the treatment time very fast. So I discussed with her and we choose the first option. She is okay with an implant, no trouble. And we extract two lower incisor with a little stripping. on the lower. Okay, so the third part is for communication with the patient. First and second part, we discussed about the treatment plan, how we can reduce the treatment time and how we can have a good treatment plan. Then we have to make the setup for explaining to the patient. Why? Yes, because the image are more powerful than our words. The must be case. When you see this case, you will ask me why we had to do mark B for this case, right? Mark B ministral assistant rabbit palatal expansion. We had to do it. Why we will see. She came to see me. Which chip complaint is the buccal corridor. So we can see the big buccal corridor here. And the important before she came to see me, she came to another clinic, and the dentist said we can do the case only use braces and the wire. Okay, so the patient was believed with the last dentist, so I had to show her this movement and explain why we had to do mark P. For the lower, we can see the lower. The posterior sector is tipped to lingual side. So we can do control tipping, and of course with control tipping is we can do easily, and we can have the ground talk after the lower posterior sector. It's good, but the ground talk of the upper posterior sector is good now. So if we do control tipping, we cannot have a good occlusion because we tipping out, and we cannot have the good occlusion with the with this one. So we have to do the translation movement. With translation movement, the teeth will out of the bone. You see, we do the bit movement around 3 to 4 millimeter translation. So it's the reason why we have to do mark P. This we explain and the result after 3 weeks. The result after 3 weeks. And the result after 1 year. You can see the crowd talk of the upper is okay. We tip labially of the lower posterior sector, and the occlusion now is still good. So then I had to show a little bone of discrepancy for her, and we finished the case. The picture before after the expansion, and the smile of the patient after expansion. Horrible, right? Yeah, the patient was very happy. So after that, she said, "Yeah, I want to remove braces. It's okay. It's okay for me, but I don't. I did not do it for her. I just said we had to do some stripping and class 2 elastic for some bone discrepancy." After communication on pluridisciplinary case with another dentist, almost for orthodontics, we communication with orthodontist or implantologist. First case, another dentist sent the case to me and said, "Please close the space, then bring back to her, and she will redo the 2 crown." But I don't understand what she say. I had to do the simulation for show her. I show her, sorry, but I don't have the X-ray of this patient because it's in my clinic. I am working in my home because of COVID, so I cannot have the X-ray. So for the movement of the upper and lower, we had to do the difficult movement around 2 to 3 millimeter translation of the lower incisor. Before do it, I had to always take a CBCT. And movement you can see is equivalent with the extraction case and maximum anchorage. This one we have to take time around 2 to 3 years and profile and everything of the patient will change a lot, and potential issue for relapse or the periodontal. So I discussed with the patient, I show her the second option. The second option is just minimal movement and veneer because she had small lower incisor and small lateral upper incisor. The veneer will be better for the aesthetic. The lower we can have the movement is more predictable, and we can compare. Yes, with the simulation we can do it very fast and predictable with this movement. For this movement is not predictable, and we had a lot potential issue after. And we had the third option for close the space and put a bridge on the implant and two veneer on the upper, but the patient don't want to have the implant on the lower, so she chose the second option. The second option, this is the result after only 4 months with aligner. We align, we muscle space for the veneer, and we change to orthodontist doing veneer for her. Yes, very good and fast treatment plan. Second case, the case from Dr. Nicolas Sales. The orthodontist sent to this case to Dr. Nicolas and say the patient want to close the space. Okay, so we do the simulation and show him. The first option, we open the space for an implant on the anterior because the patient only had 3 lower incisor. We open the space with a liner. It will be very predictable, and we can have normal overset, alignment a little on the upper. The second option is the veneer. So forget it. It's too ugly with to the patient. But even it very ugly, the patient said, okay, I want to do. But we explained to her, no, it's ugly. No, don't do it. And the patient and orthodontist want to see the simulation, how we can close the space. Yes, we can close the space, but it takes long time, and the patient will have horrible overset, like around 10 millimeter of overset. If patient want to do it, we can do it. It's just moving the teeth. But I explained to we explained to her it's not good. So I don't know the patient choose which option. The third case, the patient came to see me and want to close the space on the lower. She lost number 7 on the lower right. But she only want to do the lower, don't want to do the upper. She will do the upper only veneer on number 2-1. She had protrusion, but she don't want to change her profile. Just care about the lower space. You can see. First option, she want to do aligner. I show her we can do easy with the aligner. We push the teeth and open space for an implant on the anterior. So she will be had a fine incisor here, but it's not the trouble. She will have a good occlusion here. Yeah, we don't change the occlusion a lot, so she can have one more good occlusion. Then, because she want I do the simulation of closing the face, we had to retract and uprighting the lower molar around 7 millimeter. Even with braces with mini screw, the movement is very difficult and take a long time, almost around 2 years. So I said the patient, we can do, but you have to take 2 years of the treatment. Uncomfortable, put mini screw, and the importance, we will not have the occlusion. The number 7 is not in the occlusion. We will lose number 7. And the last case we said, so of course we cannot choose the treatment plan. Why? Lose time. 2 years. For the first option, we only need around less than 6 months or 6 to 8 months. For this one, we take around 2 years with mini braces, uncomfortable, and lost the molar. The last one, we did the aligner lingual treatment diagnostic. For this one, for aligner, we do it for mechanic evaluation, because the active setup on aligner is not the same with the diagnostic setup. For the lingual, we are doing the way with individual bending, so we had to have the from wire bending. We do the wire bending on the paper on the scanner model. Like this case, she came to see us for the lingual treatment, so I do the setup and the setup for wire bending, and the setup show us we don't need to extract on the lower lip. We can do distalization on the lower lip. When I see the patient, I see we had to do extraction for upper and lower, but no, we don't need the extraction on the lower lip. This one, if we do extraction here, we had to burn around 90% of the anchorage. So after 4 months, I align the upper with individual wire bending night time. The second case, the patient had minimal crowding on the upper and the lower, head-to-head position, +3. So I want to do distalization. I want to keep the position of the upper incisor and zone the head-to-head or anterior rod by retrocline the lower incisor. We had to do distalization on the upper and the lower, so I do the distalization simulation. It's okay. We can do it with two buccal shell mini screw and class 2 elastic. We distalize only 2 to 3 millimeter. It's good. We can do a little stripping. After wire bending and lingual braces, this is the result after 10 months with lingual braces and aligner. We only need 10 months for this patient. Lateral side, before and after. So the before and after of cephalometric, we keep the upper incisor position. I think I retroline a little, not keep in this position. I retroline a little, and I retroline the lower incisor as the setup. Okay, the superimposition, I did it with WEBCEPH.com. So the third case, the lingual case, the singer came to see us after 1 year of the treatment with another dentist, and almost nothing changed after. She want to do the lingual treatment, and I had to do the setup for anchorage, for seeing the anchorage. Why? The crown top of the upper incisor, did you see? It's retroline already. So I want to keep this profile, this round top and the position of the upper and the lower incisor. I had to see the anchorage because another dentist structure premolar on the upper already. So the simulation, I keep the position on the upper and the lower. So we had the normal, almost the normal anchorage here. We can do it down with through. And the result with the 2D and the result after aligner treatment, the lower. And for this patient, after doing the setup, I know I had to do stripping a lot for the premolar on the left. So she had the mid bone tone discrepancy. As you know, number 4 is bigger than number 5. If we extract number 5 on the lower left in the first time, we will not need to do stripping on the lower left. So the last one, the aligner case with the rocklination on the upper, spacing, little crowding, and very deep curved P. So for this case, we had to do direct intrusion on the lower around 4 millimeter and retrocline the upper incisor with stripping and with the space. So after doing diagnostic simulation, I will show you this is the active setup of the aligner. This is the setup of number 10. Did you see we have open by, bit open by between the upper and lower because we had to do the compensation of the intrusion by aligner. It's not the same with the picture. We took the picture and this is the active setup. So the diagnostic is not the same with the active setup on the aligner. We had to see it how it's different. We just do the diagnostic setup for seeing the movement, and we will see the mechanic for the active setup. And the result after 1 year. After 1 year, we had we still have a little class 2, but I cannot do continue to stripping here because the lower incisor is we did stripping on the lower incisor and now it's quite small. I cannot do it. The patient happy. The before after and superimposition of the cephalometric. It's good. So I finished the indication for 3D simulation. For normal case, for unusual communication with the patient with another dentist, and for aligner lingual treatment. After I will show you which are the case we cannot do the simulation. The first, we cannot do the simulation for the case we want to move the mandible. We want to do rotate clockwise or counterclockwise the mandible, like in open by case or in deep by case. Open by deep by skeletal, we want to move the mandible, or in functional skip case, we cannot do it. I will show you the clinical case. Like this one, open by skeletal case. This is an orthodontic surgery case. We can do 3D simulation for orthodontic surgery, but for orthodontic simulation, we only can do how the teeth fit, because for this patient, I want to intrude the upper molar and use mu for rotate the mandible counterclockwise for closing the bite. So when we intrude the lower, the upper molar on the setup, we will have open bite on the posterior. It cannot understand. So we just can know how to the teeth fit and the X-ray, cephalometric analysis. Then I did mu intrusion of the upper molar. Then I closed by, but I cannot meet this patient around 2 months, and because of COVID-19 in Vietnam. Then the second we cannot do is after the cross-bite with functional shape, or we call it Burstado class 3. Like class 1, we had the functional shape, we had the mandible move forward, but it's not the real position of the mandible. It's just shift to the forward. We can have the real mandible position in CR position. So for this case, I shown the cross-bite first, then I make the setup with braces and see we need extraction or non-extraction, or we just see how the teeth fit. Like this one, if we do the extraction simulation first, or make a treatment plan before, we difficult for see how we can do non-extraction or extraction. But I did the simulation. I shown the cross-bite, so then we can see the cephalometric. The IMPA is okay, so I don't need to do extraction on this case. I just do simulation for seeing how the teeth fit. And this case also, this case is the case communicate case with orthodontist, and I shown the cross-bite. After solving the cross-bite, I do the simulation and discuss had a discussion with the orthodontist and see how we can open space, how we can have good aesthetic, because she lost one central incisor. Okay. Okay. The last one, the last part, I want to conclusion about everything I say. Digital simulation for me is the best way for diagnostic and orthodontic treatment plan. It makes me more confident, less time on the chair, reduce the treatment time. We can understand clearly of our treatment plan, extract or non-extraction, or we have to stripping on which teeth, and how many millimeter we have to do stripping. And I always had a joke sentence to my friend: 1 hour on the computer sometimes help us say 1 year, 2 years, 3 years on the chair. And the person will very happy with us, and all of their family will come us for dental treatment. When the patient see the result, they see the result and they increase their trust me, trust them, trust us, trust about our treatment plan. But it takes time. Despite of we only need around 10 to 15 minutes for one simulation, and so total is around less than 1 hour. But the time for dentist is very useful. So never do it for free. If you do it for free, you have to do on the case. It's free, so the patient want to do it. We have to have the opposite before doing it. Never do it for free. Okay. thank you. This is everything about my presentation. Hope it can be useful for you. And if you have any question, please put on the chat box, and I will